Right now, millions of men and women are walking around with dangerous plaque silently building inside their arteries. Zero idea that one microscopic crack in that plaque could end their story in minutes. Now, fortunately, there are ways to actually find plaque before it finds you. In this video, I'm sitting down with a surgeon who works on arteries every single day. This is Dr. Johnston. She's a vascular surgeon. She spends her time opening, repairing, and protecting blood vessels that keep the brain, the heart, and the legs alive. In our conversation, she's going to show you how plaque hides in the artery wall long before symptoms, the imaging and tests that can reveal that plaque early, and the warning signs that most people just brush off. Dr. Johnston, thank you so much for joining us. We're going to be talking a lot today about arteries. I'm hearing this quote more and more often these days because it's a genius quote. Everybody's got a plan until you get hit in the face.
Oh, was that Tyson?
Yeah, Mike Tyson. That was me at age 57. I had got the bad news that I had plaque and I had some not so stable plaque. So I got hit in the face. And a lot of people, once they get into especially once they get into their 50s, 60s, 70s, get that same punch in the face and they change their plans.
I think many of us actually came to a place where we were thinking we did okay with our nutrition and our exercise. We knew it was important, but other things took over life for a while, whatever that might be, family, work, travel, and it might have gone to the back burner. And we entered another phase and we got very serious about our health and we made all these changes. And then they get this gut punch with plaque. And I will like to try to remind people that all that they have done for improving their nutrition and working on movement and that health journey was not for nothing. It doesn't mean that the plaque is their fault and that it didn't work. It means that we now have a longer runway to fix it. It makes it so much easier to manage and stabilize, if not maybe reverse that plaque. And my first point is just that some of this is genetic and it's a bad hand, and we don't all get to control how our bodies respond to the environments that we live in. Our modern environment is full of things we cannot control, like air pollution and microplastics and stress. This is all the reality of modern living. And it doesn't mean that your nutrition didn't work and your movement didn't work. And that's all. We just toss that out with the baby. We don't have to do that. It means it's so much easier to manage once our lifestyle is dialed in. And still, we may need more tools to help manage plaque. But my story, I am a vascular surgeon and I still practice in that field. I also spent a few years trying to figure out how to make peace with the fact that the disease I treat is so awful. People come to me with plaque rupture in the neck and stroke. They come to me with rupture in the leg and being at risk for limb loss and amputations, with kidney failure and the need for dialysis. And the mortality rate of peripheral arterial disease is about what it is for stage 4 cancer. This is a bad disease. And I've come to the understanding that the surgical management of peripheral arterial disease, or the formation of plaque in the arteries outside of the heart, is essentially the treatment of stage 4 cancer. Why on earth, just like the cancer doctors, would we not try to move up in our diagnosis and management of this disease process so that people don't end up on my operating table with metastatic disease where I am just putting a Band-Aid on this hole in the Hoover Dam that's about to release the floods?
On that, your story reminds me of a patient that we covered in a recent video. It's a series that we're doing. We call it House Calls. And we visited a fellow in Texas. His name is Harlan Bounds. He tells a story about how he was preteen. He was like 10, 12 years old. He and a friend were walking by a car. They saw cigarettes on the dashboard. The window was open. You know where this is going. They stole the cigarettes. He became a lifelong smoker. And he said, I knew it was going to make me probably die younger. But when I was 10 years old, dying at age 55 instead of 75 didn't make a difference. And then I became age 55. And I changed my mind about dying younger then. I was wrong. And he had very significant vascular disease. We were able to get him to where he was able to do a lot of walking, a lot of things better just with lifestyle. He changed his diet completely. He'd lost 40 pounds by the time we got started with him. He was also full diabetic. So he had two of the worst things for arteries that you can have. But you see a group of people who aren't quite so fortunate.
Yeah. And what I'd love to say about that is when you are in your 70s and you didn't really think you would live to 70 or 80, having a stroke or a limb event in your 80s and 90s isn't actually any better. It is still disabling. Somebody still has to wipe your butt for you. This is not the kind of thing where, just because you're older, it gets better. Now, I want to be clear, we're all going to die of something, right? Life is a terminal condition, and I'm not trying to prevent that. What I am trying to prevent is the morbidity and the disability and the reliance on other people to help care for you in ways that are not consistent with what you want in life, right? Whether that's being outside of the home in a nursing facility or being dependent on a medical team to help you because you can't move your arm and leg anymore. Any of these things. I had a patient who came to see me in clinic to talk about the disease in his carotid artery in the neck, and he'd had a stroke. It was his second, and he had recovered just enough to be nearly suicidal because he couldn't care for himself. He couldn't get out of his wheelchair. He couldn't feed himself, but his brain worked well enough to recognize that this was his situation for the indefinite future. Now, he has certainly the possibility of recovering more function with intensive rehabilitation and all of this, but in that moment, it was maybe the most devastating disease for him. And it was awful. It was awful to watch. It was awful to see his family be so helpless and hopeless about what they could do for him or not. And this is what I want to prevent for people. We're all going to die, right? I'm not trying to fix that problem, but I don't want us to die with disability, with these consequences of this awful disease.
So one of the major reasons of coming to see me as a doctor, we got a lot of patients that come to see us after having seen us on the channel. And they start off saying, I don't want to have a heart attack. Pretty soon after that, they change their tune and they say, hey, doc, you know what? I came to see you because I didn't want to have a heart attack. I've got a different perspective now. My perspective is I don't want to have a stroke and be bedridden for the rest of my life. So they're wanting to change their health span, not their lifespan. And I think that's why I met you at a low carb conference doing CIMTs. I think you've got, having done the work that you've done way down the road with people that are losing parts of their brain, losing parts of their limbs, you're saying, let's walk this backwards and see if we can prevent the patient getting there. Help somebody not get to your operating table.
It's so much easier when we start early, right? If you think about it as paths diverging, the earlier we start, the smaller the change we have to make when we have years or decades to work with that allow those two paths to really diverge over time. If we get to patients toward the end of that process, right, when we're in stage 4, the amount of work we have to do to get from A to B is enormous, right? We have to get all of our tools, all of our medications, our procedures, and it's a big lift to try to put that genie back in the bottle. Whereas when we start 10, 20 years earlier with a little bit of plaque that we detect in an artery on an ultrasound, we can do a lot with lifestyle, maybe all of it. We can add in some medications if we want to, and we can add in some additional tools depending on a patient's philosophy, family history, risk factors, all of these things. But the amount that can be done when we get it early is really, I think it's a source of great hope.
So for the rest of this conversation, maybe we can cover some things walking backwards. Maybe first talk about, you mentioned actually the possibility of reversing plaque. So you mentioned reversal of plaque. My first video that was popular and really was carried most of the other videos in the channel from a content creator perspective for the first 7 years was when I shared my own story about reversing plaque. And I was talking about a CIMT. You and I both know CIMT has variation, especially depending upon the quality of the technique. We can get into that at some point. But the thing was, I was at Hopkins. You were training to be a vascular surgeon. And in my training, I started off as an ER doc, and I said, I got too many people with heart attacks and strokes and stuff like this that should have, would have, could have never happened had we gone earlier. So I went into prevention straight from the beginning. And one of the things that I noticed was that people just don't listen. So you and I are going to be converging in that you're trying to get them before they lose a limb. I'm trying to get them 20 years old. The reason I went there on that was I did a lot of work at Hopkins on science and evidence. And it was really clear that no matter what you might see in terms of variability on a CIMT, once I discovered that I had metabolic disease, prediabetes, my challenged glucose was starting to hit up in the 170s, 180s. So I cut the carbs out. I lost a few pounds. I added a low dose statin, which people hate to hear. That's reality.
Believe me, I know.
And guess what happened? That arterial age, as estimated by CIMT, took a very smooth, very distinct drop from a 73-year-old artery to a 57 and then 53-year-old artery. I dropped 20 years in that. You don't see that a whole lot, but you do see it. I'll add one other thing about reversing arterial age or reversing plaque. I got tons of haters. I expected to. The typical content was, hey, I'm a PhD. I know science. My cardiologist is the head of cardiology at Cedars-Sinai, very well-respected place. He says reversing arterial plaque is impossible. Give me your perspective on that, this topic of reversal of plaque.
We share our Hopkins education. I went and got my master's in public health from Johns Hopkins. And so I, like you, share a passion for understanding the data and the science behind what we do, which also gives me an understanding of the limitations. Plaque reversal, the shrinking of these atheromas or fatty plaques in the artery wall, is absolutely possible. That has been demonstrated through the use of intravascular ultrasound, ICT in the coronaries. Like, we know that we can shrink the plaque and atheroma volume in a patient. And we also know that we can stabilize the plaque atheroma volume in a patient. What we are not sure of is whether it is really that important to reverse and shrink the plaque versus just stabilize it. I don't think that the data are entirely clear on that. Now, from a personal achievement standpoint, everybody likes when we reverse plaque. That is a very intuitively wonderful concept, and it makes everybody feel great. But honestly, from an outcomes perspective, I will absolutely take it as a win if we stabilize plaque. But the IMT is a little different, right? IMT is the intimal medial thickening in the wall of the carotid artery. And yes, when it progresses rapidly, that does become a plaque or an atheroma. But my take on the IMT is that is the active inflammation damage signal in the artery wall that lets me know that other areas that have real plaque, a 4 millimeter plaque, will continue to grow. The IMT itself probably doesn't represent its own independent source for an event. But if we bring that IMT down, I believe that represents calming of inflammation and active plaque growth in the artery wall. Now, that's not as well supported by the data as I would like, but it makes a lot of intuitive sense to me. And I don't believe there's a lot of harm in that particular approach. So for people that have had heart attacks and have stents, where cardiac imaging is a little tough, I like using IMT as my barometer for how well we are controlling the risk factors that continue to promote plaque formation.
I think that was a great way of putting it. I can't resist giving my own opinion because I run into this all the time because that concept it was almost like clickbait. It was reality. I knew it was going to be seen as clickbait, but here's my perspective on it. I don't think you really reverse a whole lot of the actual LDL components of the plaque, the oxidized LDL. I think what you're reversing when it does happen is the inflammation and the inflammatory components, the inflammatory liquids, things like that. And I tell my patients, look, I know that you saw that. I know everybody wants to reverse plaque, but that doesn't really matter. That's almost rare to see it. It's not very common. But what everybody can do is stabilize the plaque. And it's crystal clear that once you stabilize your plaque, you're approaching the same level of risk that somebody that doesn't even have plaque. So that's really the goal. It's not to reverse plaque, it's to stabilize it. I think as I listen to you from more of a science geek perspective, I think we're pretty much in line.
The other thing I'll say is if we're looking at plaque on CIMT, the plaque measurement is one of the less reliable components of that IMT exam, even from cardio risk, right? That's not something where we are taking multiple measurements from multiple angles to make sure we have the absolute peak size. So when I see plaque volume change on a CIMT exam, I take that with a grain of salt, right? If it shows improvement, yes, of course, we will celebrate and be happy. But truly, the most reliable portion of that exam, and Dr. Eldridge has done an amazing job of helping us make this a tool that we can rely on. And we can talk about why people at major cardiology divisions around the world don't believe us. But I do believe that he has done an amazing job making the IMT component especially very precise and reliable. That said, the plaque piece of it is really a yes, no, and we will take the total plaque volume as a gross measurement. If we go from a plaque volume of 10 down to 5, that's probably real. If we go from 5.5 down to 5.3, that's maybe a measurement error. But if we're looking at plaque volume on a more truly quantitative technique like CCTA, coronary CT angiogram with an AI overlay that's really doing a deep quantitative component, then perhaps I'm a bigger believer and that's where we know that plaque reversal is real, right? Those come from a little bit more quantitative studies that way.
So thank you so much for going there. Here's what's reliable. Do you have soft plaque or do you have stable plaque? How much plaque you have is a much muddier picture, even with the state of the art. And I agree with you, and I appreciate you bringing up Todd. I've had Todd, Dr. Eldridge, on my channel many times, going way deep in terms of just hour after hour of discussing what's reliable, what's not, how he achieves what he achieves. And I think he's done a great job at being able to create state-of-the-art reliability on a difficult test. Any comments from that?
I will just say I spent the better part of a decade training to be a surgeon, then a vascular surgeon. The exam I had to take for Dr. Todd Eldridge to be able to scan and provide images for cardio risk is the only double-blinded trial I have ever had to personally submit myself to in my education and training. I had to examine 5 patients who were pulled off the street of Salt Lake City. I did 2 exams for them. I was pitted up against their best sonographer of 20 years. Those results were blinded, sent to an independent statistician, and my results had to be within the standard deviation of hers to be able to say that I am reliable to scan for cardio risk and send those images in. It is the only time my skills have ever been pitted against somebody else in a randomized, controlled fashion, and I think that is an incredible achievement that he has made, and the reason that I am so confident in that tool.
Very interesting. I knew he was good. I have to tell you, I started that myself back in the early days of my channel and evaluating, seeing patients coming from the channel. I couldn't take it. I had too many different other demands on my time. I ended up handing that device back and saying, it's too much. I'm not going to be able to go deep enough, long enough to meet the rigorous requirements. Kudos to you.
It was better than I thought. And I do a lot of ultrasound it's part of my kind of point of care assessment of patients anyway. I was certified as a registered vascular interpreter for ultrasound tests. That's part of my clinical practice, is being able to interpret these different types of ultrasound tests for vascular patients. And I thought, oh, this will be a breeze, no problem. I've been doing ultrasound for years, and I had to work for it.
Very interesting. Now let's go back. People get started with us as patients. They're following up. They're doing their lifestyle things. They've made their changes. They're seeing great bioindicators. Their triglycerides are down. Their HDL's up. If they needed to lose some body fat, they've lost body fat, visceral fat. Their OGTTs, their glucose tolerance test has improved. Their insulin response has improved. And then again, they see maybe two things happen. Number one, I had one patient who expected to see a major reversal on his calcium score. Not one. I've had multiple patients go back and get a calcium score, and it was higher, not lower, and they panicked. I've had other patients who saw a little bit of a 2 millimeter increase on their CIMT, and they panicked. And I'm trying to say, look, the fact that you've already lost 40 pounds, you were in much worse shape before. You had a bunch of soft plaque now that's become calcified. But again, as I mentioned a few minutes ago, another corollary to that is I'll get somebody that's fresher on this. They got a calcium score. It was a problem. They come in, they get religion, they drop their carbs, they get healthy, and then their calcium score goes up and they panic. How do you deal with that?
If it were up to me, I would never get a second calcium score unless we were trying to get a double zero. Yeah. I think in that particular circumstance, if you were zero at one time, and that, by the way, to me is probably age 60 or older, and you want to prove to yourself and to your team that you are truly at minimal risk, and you want that double zero, which I find much more reassuring than a single exam, then I think that's a very reasonable time to repeat a coronary calcium score. But it is a screening tool. It is not designed for monitoring disease progression over time. CAC, just like IMT, naturally goes up with age. So I really try, when I get calcium score results, I really try to use the percentiles, where somebody is with respect to other patients of their age and gender in the population, because I think that's more helpful. And again, we don't know whether an increase in a calcium score represents stabilization of the 70 to 80% soft plaque that they had the last time they got a calcium score that we didn't see, versus progression of disease. The reason this is problematic is that in the cardiology literature, people with an increase in CAC over time do have an increased risk of events, because I think there are two populations that are combined in those studies. There's a group of patients who has stabilized plaque, whose event risk gets lower. And then there are patients who do not have adequate risk factor control, because the old paradigm of here's your aspirin, here's your statin, go off and you'll be fine, is inadequate for a large number of patients. And they have progression of disease. And yes, that doesn't surprise me. That results in an increased event rate. But in the era of CCTA and CIMT, I'm not sure that there's any real point in repeating a calcium score for somebody who has positive one to begin with. We already know they have plaque. What are we going to do differently with this very emotional, very stressful result? Right? What I want to know is, do we have more soft plaque? Did we convert soft plaque to calcified, more stable plaque? Is the inflammation in our vascular system improved, or is it uncontrolled? Have we missed a risk factor like periodontal disease or toxic exposures that we were unaware of? That's a minority, but it could happen. And that's why we would like to have some additional imaging going forward. But I don't think that calcium score is useful at all to me. If the first one was positive, I just would never ask for somebody to get another one.
Thank you so much. I have to tell you, we rarely get calcium score, and especially if they've already had one, because of this issue. They're going to see an increase because they've stabilized their plaque, and they're going to panic. And again, it's been painful trying to walk people back off the ledge after they do that.
Yeah, the problem is it's the most accessible tool that we have for most patients, right? You can go down to Simon Med across the street and get one for $100. CIMT, especially a high quality one, is sometimes harder to get. And CCTA, the barrier to entry is still pretty high. The radiation is not excessive, but it's not trivial. The contrast and the cost especially is a barrier for a lot of patients. CAC is the best that many people out in the general world have access to. The cardiology community has really leaned into it as their preferred tool for risk stratification, which, again, as a one-time test, I don't have an objection to if it's the best you have access to, but it's not my preferred choice. I only order it if patients really want it or if they don't have resources to proceed with CCTA or CIMT.
We've talked about CIMT, we've talked about CCTA, we've talked about calcium score. You've mentioned CCTA several times. Get us started on that. Let's talk about that for a few minutes.
Yeah, so I think there's confusion because both the coronary calcium score, CAC, and CCTA, they are both CT scans. And many patients will not understand or should be expected to know the difference. But the CT angiogram is a CT scan where they'll start an IV in your arm and they will inject contrast dye. They will actually gate the CT scanner to your heartbeat because those coronary vessels are 2-3 millimeters and they're moving a lot, right? About 60, 70 times a minute. And you can imagine that taking a picture of them precisely is challenging. So once we have a nice low resting heart rate, that dye gets injected and the CT scanner takes pictures in time with your heartbeat. And then we can see the dye on the inside of the artery, which shows us the flow channel. And it also allows us to see the plaque on the outside or in the wall of the artery, both the calcified plaque, but now, because we can opacify or make radiodense the lumen or the flow channel of that coronary, we can also see the soft plaque that on a regular calcium score, we don't. And we believe that calcium score probably represents about 20 to 30% of any given person's total plaque volume. So if your calcium score is 100, that shows, again, 20, maybe 30% of what you have total, depending on your metabolic health and your journey and all of that, of course. But in the general population, 20 to 30%. The rest of that is this soft, much more vulnerable plaque. That soft plaque is what causes plaque rupture, which causes heart attack, stroke, and limb events. So again, I think your audience is very sophisticated and savvy, and I'm not saying anything that they don't already know, but again, generally speaking, it is that soft plaque that what ruptures. The overall degree of narrowing, it's not like it's this general slow progression from 70% narrowed, then to 80, then to 90, then once it's 100, now we have a heart attack. That does represent stable chest pain when people have some squeezing or pain in the chest when they exercise that gets better with rest. It's just like the cramping in the legs we get with walking when we have plaque in the leg arteries called claudication. But that's stable, predictable, comes on with exercise, goes away with rest. That does relate to the narrowing, but generally that heart attack event is the sudden rupture of that soft plaque. And that's really what we're trying to mitigate here.
It's interesting. Common sense doesn't work very well in a lot of the things that you and I do where we overlap. And one of those is the mechanism for heart attack. Common sense is like, if this is an artery, the plaque just slowly squeezes the artery off until you can't get flow anymore. And that's a heart attack. And that's not at all. And when you think about it, if that were what happened, then we would be able to predict a heart attack. And we can't. So something else is going on. And it's exactly where you were just going. You were saying it's not the stable. There's two types of plaque. There's stable plaque and then there's unstable plaque. And then once you get to your level of looking at plaque, there's at least three and then more, maybe. But it's when you have it's that unstable plaque that really causes the risk because it can leach out or not really break off, but it can squeeze out. And when it does touch the blood, it can cause a clot. If the clot's big enough and it goes to the heart, that's a heart attack. If it's big enough and it goes to the brain, it's a stroke. If it's microscopic and it's going on every day, microscopically, your heart muscle or your brain tissue can start looking like Swiss cheese, which is not a good thing. So there are a whole bunch of ways of evaluating plaque. You and I have talked about the three big ones now: CIMT, calcium score, which I think we agree on the basics on both of them. Calcium score is very easy to get. And for the most part, it's more objective, easier, harder to mess up than CIMT. But it's just not helpful because all it tells you is about stable plaque. It doesn't tell you about the type of plaque that causes risk, soft plaque. Then we talked about CIMT. We agreed that CIMT is great. The amount of plaque is what everybody tends to focus on. And unfortunately, that's the least reliable part of that test. The test's hard to get. You really want to know how much soft plaque is there. So we've started to circle around what you call CCTA, coronary CT angiogram, where we use dye and we look deeper. And that's been around for a long time. I really didn't start using it until AI analysis became available. You're deeper into this world. You may have used it more before than I did, but I always felt like manually read CCTAs just weren't that much more helpful than a good CIMT. But now that the AI analysis is here, I've changed my mind. I'm tending to use that as the more definitive study at this point, at least in terms of plaque analysis. Any thoughts from your perspective on this?
Absolutely. And I completely agree with you. The overlay analysis has changed the game. And let's think about why that is, because from a cardiology standpoint, and it was overwhelmingly the cardiologists who were ordering coronary CT angiograms, we are all still focused on the degree to which the artery is narrowed, because generally speaking, the indications for things like stents or angiogram procedures relate to the degree of narrowing and the location. So CCTA was useful for determining where the plaque was, but the radiologists or other physicians who were reading it were all focused on the plaque growing in to the lumen of the artery and how narrowed it was. If there were some plaque there, but it didn't significantly narrow the channel, then they didn't really mention it because, again, no cardiologist really cares about that in an old era where we were just talking about indications for stenting. But we know, you and I, who've dived more deeply into the pathogenesis of atherosclerosis, plaque begins to grow out first, right? Your body will do a lot of things to try and preserve the amount of blood flow going through these pipes. So the plaque actually begins to grow outward before it ever starts to narrow the channel and create a stenosis or an area that is significantly narrowed. And I think when we were initially interpreting CCTAs by hand or by human, the focus was always on how narrowed is the lumen. And there was no appreciable way to, again, quantitate the amount of plaque burden, right? Could it be one tiny small focal plaque that causes a 90% stenosis in one spot? Or do we have the same total plaque volume spread out through the entire vascular tree in the heart? You and I might say that's not exactly the same patient, but if the plaque burden is the same, we have a problem either way. The original human read of that CCTA is one patient is a walking time bomb, quote unquote, and the other is completely fine. I would not say that. So what AI has allowed us to do is take away that myopic lens of just worrying about narrowing and quantitate the total plaque burden, and then also get really deep into exactly how much radiation does the plaque absorb, and therefore how soft and vulnerable and likely to rupture is it versus the more heterogeneous plaque that is beginning to stabilize versus that total calcified plaque that still shows up as the CAC or an Agatston score as that component of a CCTA. So it has changed the analysis and the types of plaque, which was really not done by the radiology folks who were reading them initially. And it's changed our ability to quantitate the burden of plaque and its distribution in the entire coronary vascular tree.
Let me give my interpretation for the folks that are not quite as deep into this. So basically what you're saying is most folks are looking at plumbing. They're looking at how much blood flow you're getting. But the bottom line is most plaque that is stable may look like it's impacting your plumbing, but it's not going to cause a heart attack.
If you're an asymptomatic patient, I completely agree. There is value to the plumbing evaluation for patients who are having chest pain or atypical symptoms or were concerned that narrowing may be impacting the function of the heart muscle. And there are some interesting tools that we now, CT, FFR, fractional flow reserve, that can allow us to understand, even in more depth, the impact of these plumbing issues. But from our prevention hat perspective, when we're talking about somebody who is just coming to see us to make sure that they don't live the same story that their dad and their brother and their uncle had with a heart attack in their 40s or 50s, and we're just looking at that plaque burden to say, what do we need to do to help reduce those risks? That is absolutely correct. It's really not about the plumbing. It's about the plaque.
Yeah. If you've got angina, chest pain, that's a different category we can talk about later. But for the typical patient, the plumbing's not the issue. And I'm going to quote the Princeton Longevity Institute and several other people who've said, look, the majority of heart attacks happen in people who really don't have an impact on flow. They don't have a flow problem, but they have plaque. It's soft. It's not enough to impact flow, but they're still having a heart attack. And it gets back to the mechanism that you and I talked about before. They have soft plaque, and some of that soft plaque creates a clot, and the clot goes to the heart. So if the plumbing is not the issue, what do you look for on a CTA with AI?
What I personally really want to know is how much of that very soft, vulnerable plaque do we have? How much of that heterogeneous plaque do we have? And where is it? And again, in some ways, it's a yes/no question, but for the very data-driven like you, I have some engineers and some folks who are very specific and like more data, then we can really understand what the total plaque volume is. There are some interesting proposed staging systems now where, again, I made reference to this idea that as a surgeon, the PAD that I treat is this like stage 4 disease by the time you need an operation for it. But what if we could actually stage cardiovascular disease just like we stage cancer? And if we could do that, then again, maybe now we have different thresholds for risk reduction in terms of our biomarkers. Do we start with all of the tools in our toolkit, or do we get to go one at a time and then repeat imaging and see how we do? And it allows us that opportunity over time to remeasure and see, again, have we converted unstable into stable plaque, or are we forming more plaque? Are we not doing well enough?
So when I have my engineers, especially the data, the get into the detail, emotional data driven engineer, I drive them crazy because they go through all this trouble. They get a CT and then they get the AI analysis. And sometimes, I'm sure you run into it all the time too, where the local group says, yeah, we'll do the CT with AI. And they bring the manual interpretation. They don't bring the AI interpretation yet because the patient doesn't know. They just rely on the system to do the stuff. And they find out the hard way again and again that the system's not really watching out for them as much as they think. And so they finally go through all the trouble to get the AI analysis. And they want to talk about this anatomy and that anatomy and plumbing. And I'll say, look, all of that's plumbing. That's great. It's not really going to impact you so much as one number. And then I go to the soft plaque. And then I'll say, yeah, okay, there's two other numbers that we really want to know. Your total plaque and what portion of it's heterogeneous, what portion of it is soft. And it drives them crazy. But that's what I do.
I think it's a little helpful in the sense that we can talk about if they are those patients with a calcium score of 1,000 or 2,000, we can see the distribution and we can say, look, I know that somebody's told you you're a walking time bomb, but we only see this in one vessel, right? It's only in the left circumflex. You don't have 3-vessel disease. You don't need a cardiac cath if you don't have symptoms. There's no evidence that stenting that one lesion in that one spot is going to do anything for your mortality. Or conversely, you might have 3-vessel disease or a left main equivalent. And perhaps under those circumstances, I will send that patient to an interventional cardiologist for peace of mind to say, okay, would you consider a true invasive coronary angiogram to confirm and see whether this patient might warrant treatment for asymptomatic disease because it is a left main equivalent. There is one population of patients. I'm just a dumb plumber vascular surgeon, right? I'm not trying to be a cardiologist or play one on television, but my best reading of the literature is there is one group of patients who does benefit from treatment of severe asymptomatic coronary disease, and those are patients with left main. So there are two coronary arteries, the right and the left. The left gives off a trunk, and it is considered in most patients the gateway to the whole left side of the heart. And if you have severe plaque in that left main artery, or in all three big branches of it, which is the same as basically having it in the main trunk itself, then that very specific population of patients, which I think is a minority of the folks you and I see, they might benefit from prophylactic treatment.
So we've talked about people that you've trained for, you're trying to never see again. You're trying to put yourself out of business. And that's the people with peripheral artery disease where you're having to take a limb off. And as you said, that's like a stage 4 cancer by the time you get to your operating table. And I never want to be there. I enjoy spending time with you, but that's not the way I would choose to do it. I don't want any of my patients to become a patient on your operating table. So we've walked it back to, okay, let's look at arteries and how to evaluate plaque in those arteries. Now, you've got a patient who has a problem. You've seen them. They've said, look, I've got a 30-year-old son, and he reminds me very much of me. He looks like me. His body's built like mine was. Can we keep him healthy into my age? Do you ever run into that?
Yeah, I have at least one family that I treat. I started with dad, and then it was mom, and now it's the son as well.
Tell me about it.
I think, it's horses and water, right? What I have come to understand in this prevention space is that people have to be ready to make change. The best changes that can be made are ones that patients do themselves. And that starts in the kitchen. It starts in a commitment to movement and to understanding the role of stress and sleep in our lives and working on all of those things. And they are hard. They are simple, but they are challenging. And there is no pill that I can give that will substitute or do better than any of those things. And people have to be ready for change. What I will say is that patients in their 20s and 30s care much more about how they feel day to day and sometimes how they look, rather than, again, this concept of I'm a 10-year-old stealing cigarettes off the dashboard of a car. So what if I die at 55? That's forever from now, right? And 30-year-olds don't think about needing somebody to wipe their bum for them or having to pee in a urinal at the bedside because they can't walk to the restroom. Like, they don't have those thoughts. They can't conceive of it. It's not part of their lived experience. And I don't blame them for that. But what I find is that patients at that age will tell me, I drink 8 Red Bull a day because I don't have any energy and that's what it takes. Or I've been heavy, big boned all my life. It's just how I am. I have given up because I tried eating less and moving more and it didn't work. So why would I keep trying? What I find is hopeful for those patients is restoration of hope that there actually is an evidence-based approach that can help them feel better and do the things they want to be doing, right? They want energy to play with their kids or play on their ultimate Frisbee team or not have joint pain and need their knee brace, whatever the case may be. If you ask about how people feel and how they look and how they show up in their day-to-day lives, usually there is something I can pull on in there that can reignite a desire to make some changes.
As I mentioned before, I was smart enough when I was younger to say, hey, you know what? I don't want to go into surgery. I don't want to go into cardiology. I want to prevent all this stuff from the very beginning. But you're right. It's very much
smarter than I am, Ford.
At least on that thing. But the problem with doing that is you become very much at risk to this horses and water thing. You run into frustration time and time again that somebody's not listening. To get back to the original quote from Mike Tyson, like my friend Harlan, when he was 10 years old, he had a plan. I'm going to smoke, and it's okay if I die a little bit younger. And then maybe my doc's telling me I got a touch of sugar. I don't eat much sugar, but I will keep eating my biscuits and gravy, because just not understanding a lot of that. And then he gets hit in the face with he can't walk. I agree with you. I would like to get the younger population, and I do get them. Most often it's because dad got hit in the face,
Mm.
and
Mhm.
dad's making sure that his son or his daughter doesn't get hit in the face too. It's all about motivation.
Yeah, I find that fear is not a super profound long-term strategy. I don't think you can bully people into this change. You can't shake their CIMT at them and say, look what's going to happen to you. Scaring people without hope is a challenge, and I don't think it sets the tone for a good therapeutic relationship going forward. People tend to panic. They tend to go Dr. Googling and go to Reddit, and they find all these horror stories, and they get really discouraged and they just give up. And so my strategy for the younger patients is, remember, the atherosclerotic pathway takes us decades, right? We have a
Yeah.
long runway. So pick one little thing that they are willing to do and build that trust, get an easy win, right? Whether that is a daily walk, whether that is maybe skipping breakfast and just cutting out that oatmeal or the biscuits and gravy, and just one meal at a time, making some change and just doing it nice and slow and getting people the confidence in themselves that they can do these things, that they then feel better. Then they trust us. Then they like, oh, Dr. Brewer actually knows what he's talking about. I do feel better now that you mention it. Now I get 2 Red Bulls a day instead of 8, and I can use the sugar-free ones, and I actually maybe don't need them anymore. Maybe I could cut that out. Should I cut that out, Dr. Brewer? And so you get this, and you see the spark come back in people. And what I have learned is that it takes more tools, right? Sometimes we have to do some work on hormones. Sometimes we focus on nutrition. Sometimes it is the movement piece. Sometimes it's sleep, right? Getting people screened for sleep apnea and getting that treated can be a huge win. So when you have a big tool basket, you get to pick one, you get to start slow and build that trust and let people recognize that, in fact, they were not feeling well, and you can do some little things that are achievable. And then once they win, they'll follow you across the river. They'll do it. They'll do whatever you say.
Anyhow, anything that we should have covered today, Lily, that we didn't?
Again, you and I have both hinted at the importance of glycemic control in the whole plaque process. I think maybe it's time to get together another time and talk about, there are a lot of different ways that we end up with plaque, but they're different diseases, I believe. There's an inflammatory component. All of our patients with rheumatoid arthritis and visceral adiposity and autoimmune disease, right? They're predominantly driven by inflammation. Then we have the patients who have an inherited dyslipidemia, Lp(a), FH, things like that. They also end up with plaque, but I don't know that it's the same disease process. It looks the same in the end. And then the smokers, nicotine, heavy metals, toxic exposures like microplastics, that is probably a separate category. So anyway, there's a lot to talk about. I think nutrition is a big thing that we're both very focused on, and maybe we'll do a part 2. Or maybe you'll come on my podcast and we'll explore all that.
I was going to say, yes, let's do that. Let's get together on your podcast next. Most people don't know this, that diabetes rots your arteries, but they don't know how common diabetes is. Most docs have no clue that rheumatoid arthritis rots your arteries as bad as diabetes. It's just that so few people have rheumatoid arthritis. Again, it just goes right over the head. They don't know it. And there's another type of inflammatory arthritis called psoriatic arthritis. It's similar to rheumatoid arthritis. It's another inflammatory disease. And their rheumatologist is following them with some of the same things I'm following them, very specifically C-reactive protein.
Yep.
And as you said, it's a different disease starting from a totally different perspective, but it ends up creating the same inflammation from a vascular perspective, an arterial perspective, that you see from having too much glucose and insulin. So yeah, maybe we can start with that when we get together again.
Let's do it.
Okie doke. Thank you.
Thanks, Ford.
Bye-bye.
Bye.